So this one, guys, is with safe medication administration, and we're going over with, you absolutely have to know, like with medication errors, what are some of the reasons why errors are, happen, and go back and review your 8 rights. You need to know those. With the system checks, we know again that the nurses, you would be the last stop before you give that patient the medication. As far as with the patient's role is, again, we try to educate them to be able to keep a list and to be as knowledgeable about their medications as much as possible. Not everybody has an interest, not everybody is capable of it, but we certainly do attempt to educate them to keep on top of their medications. With medication errors, again, what were some of the reasons that could cause it, or when a medication error occurs, what are you supposed to do? So go back over that. We know that are certainly preventable, and that they can cause an adverse health effect for the patient and affect how that patient's outcomes, to have poor outcomes. Okay, so we know that there's those high alert medications, there's sound alike, look-alike medications. And so thinking about what strategies do hospitals help put in place to help decrease those errors. Well, you'll see drug labels, again, like caution. You'll see labels if it's maybe as a high-risk medication because it can make the patient drowsy. So there's a lot of things in place to help draw your attention as to why to be very careful and cautious about that medication. Another thing with the medication errors is, as far as like trying to prevent one, and I think we talked about it, but I'm not sure. Like as a nurse, when you are given an insulin injection in the hospital, you are supposed to have another nurse double check it with you, because you potentially, maybe you thought you were seeing like 10 units and you really pulled up 15 units or something. So we do double checks. Okay. We talked about when you're looking at prescriptions, what all information has to be on that prescription. So we don't see a lot of handwritten prescriptions anymore, but even regardless if it was handwritten or even if it was entered in the computer. We said we're never going to assume anything about that order. If anything is missing, you need to contact that provider. You have to clarify that order. Do not try to figure it out on your own. Okay, another thing we talked about as well, excuse me, is when patients are unable to swallow pills, or you have a concern about them swallowing, you can't just change it. You have to notify the provider in order to get a new order for a route. So the way the route of the medication would be administered. So I said maybe it's going from oral to liquid, oral to a suppository, or IM injection or IV, but you have to call that provider to get that order. Okay. We talk about those zeros, so we never want to use a trailing zero, or making sure that we have that zero that needs to go before that decimal point, so either or if needed. So go back over and look at those drug labels. That leading zero was the word I was looking for. Okay, because thinking again, if somebody did not put that leading zero or the trailing zero, you can very easily misinterpret that milligram dose of that order. Another thing too is that when listening to patients, and I know I gave examples of, if a patient said, my pill at home is blue, I don't want to take that one, or what is that one for? Well, mine is blue, and they're very adamant. We do try to listen to that patient, but the thing that you can do as a nurse is, or if they say, I don't take that medicine at home, and they, they're pretty knowledgeable about what they take, then you don't give the medication. You would go try to look into the chart, clarify it in the chart. And a lot of times you'll find the provider say, patient will be started on this medication for this reason. And then you can go back in and share it with the patient. If you really cannot verify it in the chart notes anywhere, then you absolutely can clarify it with the provider. Okay. Again, 2 patient identifiers, name, date of birth, match it with the ID band, and we do not use room numbers for identification purposes. We know as RNs we can do telephone and verbal orders, so there are specifics again that if you are doing telephone or verbal orders, we do try to do it only if necessary, because again, sometimes you can misconstrue information or directions or so forth. The best practice is really to have a second nurse listen in on that phone conversation, because 2 ears is better than one. That you covered all the components of the order, repeat the order back, speak slowly, make sure you document it in the chart, right? And that it is something that is within your scope. Okay. When we talked about reporting medication errors, we talked about that we do not document them in the patient's chart. They're going to go on an incident report. But we talked about too, if a medication error occurs, then what do you need to do? And we talked about you do have to notify the right people, whether that's your floor manager, clinical nurse manager, or unit manager, the physician. You will be documenting factual documentation only on the med error report. So again, avoiding that terminology as in an error occurred or something like that. Okay. Other than that, I think that is pretty comprehensive of the main bulk for medication errors. Okay, last one, patient education. So looking at patient education, we said there's 3 areas or domains of learning. Affective is where they will express their beliefs, their opinions about something. Cognitive is where they're learning and storing that information, kind of that thinking portion. And then psychomotor is usually that doing domain. So kind of where maybe your teach back would happen, like they're learning a new procedure or something like that. We said there's a lot of different factors that can come into play when trying to educate. And so we think of it language barriers, coping mechanisms, cultural backgrounds, cognition, sensory issues. We talk about financial status, and health literacy is also very important, right? And we talked about having to make your education at a level that your patient will be able to understand in. And again, health literacy can be across the board, and it's more than just being illiterate. Is that a lot of people are not versed in health terminology, healthcare matters. And so again, just making sure that we try to educate and give them information and to make them more knowledgeable of their medications or health condition, but again, at their level. Okay. So I said it before, but again, with current medications, they do include over-the-counter, herbal medications. It might be essential oils. One thing too, and I forgot, is that a lot of people are using CBD oil now, and so that would be also something that you may want to ask your patients if they're using that, because you never know, it could certainly interact with a medication. So just know the different factors that could really limit somebody with their education as far as being receptive or learning, those barriers, okay? When we talk about maybe some nursing diagnosis, one of the things when we said readiness to learn, so that reminds me of a nursing diagnosis, but also in your patient. So that readiness to learn, like I said, a lot of patients will shut down and not really want to hear what you have to say. Maybe it's because they're trying to process their diagnosis or something like that. And so that readiness is if they're in the correct state of mind in order to process the information you're going to share with them. Again, you may have certain religious beliefs that that patient will not participate in taking a medication, or we talked about blood products, right? And then with self-care ability, just if they're able to care for themselves at home and can they administer that medication at home. And sensory, we talked about if I give somebody an insulin syringe and they are like legally blind and I'm trying to tell them to pull up their 1 unit of insulin, how successful is that going to be? So really knowing if they have the dexterity to do those tasks and those sensory. Okay. Go back again over your nursing process. Again, you have to be able to identify what each of those 5 steps are in regards to your patient scenarios. And then also there are some different nursing diagnoses when it comes to patient education. So that deficient knowledge, it can be risk for falls, risk for injury, ineffective self-care management, and so forth. Go back to your SMART goals, and again, when we are doing education planning, this is where we are determining what we want our patient to accomplish. So when we get to that evaluation, remember we're going to evaluate, was what I planned for back in the planning stage, was it actually met, unmet, or partially met? And so your SMART, again, specific, measurable, achievable, realistic, and a time-based. When you're implementing your plan of care, again, this is a lot of times in your plan of care or that implementation stage, you should have at least some type of education. This is your action portion of like your care. Okay, so you might be providing the patient or their family again with written material appropriate at their reading level. Okay, or those age-related changes. So do they need a large print version of whatever you have, and can they hear you okay is a big one. Also a translator, if a translator is needed, or interpreter. We talked about the teach-back method, or how do I know if my patient understands what I've told them. And so again, looking at trying not to ask just yes and no, those open-ended questions. Have them provide a return demonstration if it is something that they're a technique or a procedure they're learning to do. Okay. Okay. And I think that's really about it. I think it's pretty straightforward. In regards, so just a kind of a quick review. So kind of go back and focus on what I shared with you there. And going back over with last week's content, so just a quick overview again is, if you remember when we talked about pharmacology principles, so going back over and looking at some of those beginning definitions, what does the word actually pharmacokinetics mean, or pharmacodynamics? And then we talked about absorption, metabolism, excretion, and distribution. You need to know what are each of those, because and why do we care about it. So again, we learned that it's not, if somebody has like a chronic medical condition, or let's say again liver damage, and that liver is not functioning properly to break down that medication, then that person can potentially get toxic from the medicine, or they have not great kidneys, and so those kidneys, will help excrete all of these toxins that need to be excreted every day. And so that really goes into, and then factors that can influence, like make it better or decrease the way the absorption or distribution or metabolism is in the body. We looked at different routes with medications. So we talked about routes that are slowest to fastest. We talked about enteral versus parenteral. What do those entail? We said that the first pass, remember that one is for your oral. And so what is first pass, and which not medication, but what routes participate in first pass, what routes do not. Also looking at when we talked about half-life. So again, what is half-life and why is that important? Because it does let us know kind of when we would anticipate the effects of that medication to wear off. When something else I was thinking about with education, we talk about different reasons why patients may not be taking their medications, and we said that we always, not only are we asking what medications do you take, but I always ask my patients, are you taking these medications faithfully every day? Or have you been missing them? Have you stopped them or something like that? So that's also another thing that we want to check with our patients. Okay. A couple other things that we talked about when it comes to like pharmacology principles, and that was when patients take drugs at like a certain dose for kind of a longer period of time, their body builds up a tolerance to it, and so then they find that that dose does not help them as well as it did, or doesn't help them at all. So then the provider's looking at changing medication or increasing the dose. So tolerance is different than a physical dependence on it. And we do know, again, that there's certain medications that cannot be taken together or shouldn't be taken with food, or medicines that are better absorbed when they're taken on an empty stomach. With the nursing process drug therapy, I know I already mentioned like that ADPI, so again, you have to know each of those 5 steps, what goes into each of those 5 steps. We talked about that assessment is like your very first kind of piece. I cannot formulate anything else until I've made my assessment. So that's all that subjective and objective data that you will gather. With the nursing diagnoses, we've talked about, you remember, we're picking up priority ones and listing them in order. So typically, like I said, usually if you think of that airway, breathing, circulation, airway is certainly going to trump somebody who is constipated, for instance, or has a risk for, right? So thinking about that. With the planning, again, this is where you are determining what you're going to put into place into that implementation phase. And so these are your goals and your outcomes that you're trying to set, like those SMART goals, again, of what you want your patient to be able to achieve. All right, we went over drug rights, so those 8 rights as well. In the evaluation portion, again, this is where you are going to determine your patient's outcomes, your patient's goals. So what was their therapeutic response? Meaning, did they respond in the way that you had determined that or hoped they would back in the planning stage, right? So goals met, unmet, and then, or partially met, okay? All right, talking again just about medication orders, and just that there are rights to medication orders, not just with that med administration we already talked about, but knowing again, do I have everything complete on this order that I need to successfully pass this medication to this person? So their name, their date, the routes, the dose, the frequency, if there's any special instructions like parameters for blood pressure or something, parameters for pain. And then also we talked about if it's ordered as PRN as needed, they really have to have a reason why it's ordered PRN. So if it's like PRN for headache, PRN for fever, and that really technically you're not supposed to give the medication, that PRN medication, for anything other than what the provider has listed it for. All right, guys, we will see you next week.